Hello everyone, I am Balaji MK. I am here to give seminar about the topic microcytic hypochromic anemia. Microcytic, it means RBCs are reduced in size. Hypochromic, it means RBCs are pale in color. Microcytic hypochromic anemias are a group of disorders characterized by the production of small and pale red cells, most commonly due to defective hemoglobin synthesis. They comprise of five types: iron deficiency anemia, thalassemia, sideroblastic anemia, anemia of chronic disease, anemia of chronic lead poisoning. Chronic lead poisoning is also known as plumbism. Let's talk about iron deficiency anemia. Iron deficiency anemia is the most common nutritional disorder worldwide and results from negative iron balance, leading to impaired hemoglobin synthesis. It is characterized by decreased body iron, impaired hemoglobin synthesis, and microcytic hypochromic anemia. Etiopathogenesis. Mostly it is caused due to dietary deficiency, whereas iron deficiency and vitamin A deficiency, they both require for RBC production, hemoglobin production, and malabsorption, gluten-induced enteropathy, atrophic gastritis, and gastrectomy, which it's because HCl secretion is reduced, and increased blood loss. It's because of peptic ulcers, hemorrhoids, malignancies of stomach, hookworm infestation, menorrhagia, repeated pregnancies, hematuria, and chronic dialysis. And also in case of increased physiological demands, pregnancy and lactation. Pathogenesis, decreased iron stores, decreased serum ferritin, decreased hemoglobin synthesis, RBCs become small, RBCs become pale, hence it is known as microcytic hypochromic anemia. RBCs become small due to decrease in MCV, mean corpuscular volume, and RBCs become pale due to MCHC, mean corpuscular hemoglobin, and leads to anemia. Here is the peripheral blood smear of the iron deficiency anemia, where we can see those pale RBCs, hypochromic RBCs, and also we can see the microcytic RBCs. See. And also we can see pencil cells. Pencil cells are formed due to reduced hemoglobin and abnormal RBC membrane formation. So the cell become thin, elongated, and the pencil cells are also known as elliptocytes. When it comes to laboratory profile, hemoglobin it is decreased, MCV decreased, MCH decreased, serum iron decreased, ferritin is also decreased, transferrin saturation also decreased, but TIBC it is increased because total iron binding capacity is increased because the body tries to compensate for the low iron availability. So, if there is no iron availability in the diet, so liver will increase the transferrin production. So body tries to compensate the loss and low iron availability. Hence, TIBC is increased. And clinical features. General anemia symptoms such as pallor, fatigue, dyspnea, and palpitations. Epithelial changes such as glossitis, angular cheilitis. And when it comes to treatment, first we have to treat the cause. If there is any chronic blood loss, we have to treat the blood loss and we have to stop the bleeding. And then if there is any hookworm infestation, we have to perform deworming and we have to improve the diet. Main thing is we have to improve the diet so the availability of the iron is increased and RBC's production will become normal. Let's talk about thalassemia. Thalassemia is a genetically heterogeneous disorder caused by germline mutations that decrease the synthesis of either alpha globin or beta globin, leading to anemia, tissue hypoxia, and red cell hemolysis related to the imbalance in globin chain synthesis. In thalassemia, the globin chains are structurally normal, but synthesis is reduced or absent because of gene defects. This imbalance is central to pathogenesis. Thalassemia is a quantitative hemoglobinopathy, distinct from qualitative hemoglobinopathies such as sickle cell disease. And in normal hemoglobin structure, where we can see four globin chains and heme, in normal adult hemoglobin, two alpha chains are there and two beta chains are there. In fetal hemoglobin, there are two alpha chains and two gamma chains. And alpha globin cluster is present on the chromosome number 16, and beta globin cluster is present on chromosome 11. Genetic basis: alpha thalassemia. Due to deletion of alpha globin genes, alpha thalassemia. It's due to deletion of alpha globin genes, and there are four genes, two from each chromosome. Okay. And severity depends on how many genes are missing. If there is one gene missing, they are known as silent carrier, and if there are two genes are missing, it's known as minor alpha thalassemia. And if there are three genes are missing, it's known as moderate to severe thalassemia. It's also known as hemoglobin H disease. And if four genes are missing, it's known as hydros fetalis. Beta thalassemia, caused by point mutations affecting beta globin production. Clinical impact depends on whether one or both beta genes are mutated. Major forms known as thalassemia minor, intermediate, and major. How the disease develops: chain imbalance. If the beta chains are reduced, obviously alpha chains will be excess. Then unstable aggregates will form and RBC membrane damage and apoptosis will occur. Reduced alpha chains. It leads to excessive beta or gamma chains, and they form tetramers, which are very ineffective. So let's see the pathogenesis of beta thalassemia major. So we can see two alpha and two beta chains. This is normal erythroblast, and if there is reduced beta globin synthesis, which relatively gives excess of alpha globin. So this is abnormal erythroblast. So which leads to ineffective erythropoiesis, and most of the erythroblasts die in the bone marrow itself, which leads to suppression of hepcidin and increased iron absorption in gut enterocytes, and which leads to systemic iron overload. And hypochromic red cells which are destroyed in the spleen. So extravascular hemolysis will occur. It means the destruction of aggregates containing red cells in spleen, which leads to anemia and tissue hypoxia, erythropoietin increase. If erythropoietin is increased, bone marrow expansion will occur, which leads to skeletal deformities. We can see further. Clinical presentation: beta thalassemia, minor trait, usually asymptomatic or involves only mild anemia. Physical findings are typically normal. Intermedia presents with moderate anemia and varied clinical picture. It is characterized by fatigue, pallor, and jaundice, but patients typically do not require regular blood transfusion initially. Over time, complications like splenomegaly, gallstones, and bone changes may develop. Major: the more severe form, manifesting early in life, it presents as severe. The more severe form, Manifesting early in life, it presents as severe anemia, failure to thrive, and significant bone deformities such as frontal bossing, protruding forehead, and maxillary overgrowth, is known as chipmunk faces, and lifelong blood transfusion is required for survival. Alpha thalassemia. Alpha thalassemia severity depends on the number of missing alpha globin genes. Hemoglobin H disease results from three missing alpha genes, leading to moderate to severe anemia. Symptoms include fatigue, pallor, jaundice, and hepatosplenomegaly. Severe cases may show bone changes similar to beta thalassemia. Hydros fetalis, which is also known as alpha thalassemia major, the most severe form where all four alpha genes are missing. It causes profound anemia and fluid accumulation in fetal tissues and organs. It is usually fatal in utero and shortly after birth. So we can see beta thalassemia major here. It is an X-ray film of an skull showing new bone formation on the outer table, producing perpendicular radiation resembling a crew cut. Symptoms: anemia related symptoms such as fatigue, weakness, pallor, and shortness of breath. Physical findings such as jaundice, dark urine, and abnormal swelling due to an enlarged spleen or liver. And developmental symptoms such as slow growth, delayed puberty, and failure to thrive in children. Skeletal changes: bone deformities, particularly in the face and skull, caused by bone marrow expansion trying to produce more red cells. Incomplete blood count, hemoglobin is decreased, MCV is decreased, MCH is also decreased, and RBC count, it is normal or increased. It is an important differentiating point from iron deficiency anemia. And red cell distribution width, which is usually normal or mildly increased. Microcytosis is disproportionately severe compared to anemia. And this is the peripheral blood smear where we can see microcytic hypochromic RBCs, target cells, anisopoikilocytosis, basophilic stippling. In this slide, we cannot see basophilic stippling, but in usually it will be present in the thalassemia, and nucleated RBCs only in severe cases. And bone marrow, marked erythroid hyperplasia, massive proliferation of erythroid precursors, marrow becomes erythroid dominant. Myeloid to erythroid ratio is normal range is 2 is to 1 to 4 is to 1, but in case of thalassemia, ME ratio is decreased with, for example, less than 1 is to 1 because erythroid cells are greatly increased. Ineffective erythropoiesis, many RBCs many RBC precursors die inside the marrow before maturation due to globin chain imbalance and membrane damage. Hemoglobin analysis. Complications. Iron overload leads to cardiomyopathy, liver cirrhosis, and endocrine dysfunction, such as diabetes and hyperthyroidism, and gallstones from chronic hemolysis, bone deformities and fractures, growth retardation and delayed puberty, increased infection risk, and heart failure. Sideroblastic anemia, a group of disorders characterized by impaired heme synthesis, leading to accumulation of iron in mitochondria of the erythroblasts, resulting in the formation of ring sideroblasts in the bone marrow. It is a disorder. It is a disorder of iron utilization, not in iron deficiency. Iron is available but cannot be properly incorporated into heme, which accumulates in the mitochondria of erythroblasts, forms ring sideroblasts. Normal heme synthesis. Heme synthesis occur partially in mitochondria and partially in cytosol. Key rate limiting enzyme is ALA synthase, and it requires vitamin B6. In sideroblastic anemia, this pathway is defective. Classification. Congenital, usually X-linked, mutation in ALAS2 gene, impaired heme synthesis. Acquired. Clonal, myelodysplastic syndrome with ring sideroblast, and secondary is a reversible cause. Pathogenesis, defect in heme synthesis pathway, reduced activity of enzyme, especially ALA synthesis, or impaired protoporphyrin formation. Failure of iron incorporation. Iron is delivered normal to erythroblasts but cannot combine with protoporphyrin to form heme. And mitochondrial iron accumulation. Excess iron accumulates in mitochondria of erythroblasts from perinuclear ring pattern. Oxidative damage and cell injury. Excess mitochondrial iron generates a reactive oxygen species, causes membrane damage. Infective erythropoiesis. Many erythroblasts die in bone marrow. Systemic iron overload. Iron is not used, so it accumulates in the body. Laboratory findings. In complete blood count, MCV is less than 80 femtoliter and MCH is decreased and hemoglobin is also decreased. Iron studies increased serum Fe plus 2 and increased ferritin. And in blood smears, we can see basophilic stippling and ring sideroblasts. See, this is the basophilic stippling where we can only see in the peripheral smear and we can see ring sideroblast on bone marrow. These are the ring sideroblasts. Clinical features. Symptoms of anemia, fatigue, pallor, dyspnea, iron overload symptoms, especially in chronic cases such as hepatomegaly, endocrine dysfunction, cardiomyopathy. Alcoholic patients may show liver disease and neuropathy. Complications. Secondary hemochromatosis, organ damage, and progression to acute myeloid leukemia and in the myelodysplastic syndrome. Anemia of chronic disease. A mild to moderate anemia occurring in patients with chronic infections or inflammatory disorders, malignancies, or other chronic illness characterized by impaired iron utilization and decreased erythropoiesis, which leads to anemia of chronic disease. Conditions associated with anemia of chronic disease. Chronic infections such as tuberculosis, osteomyelitis, endocarditis, and chronic inflammatory disorders such as rheumatoid arthritis, systemic lupus erythematosus, and malignancies such as lymphomas and carcinomas, and in chronic kidney disease. Normal iron physiology. Iron is absorbed in duodenum and transported by transferrin, which is stored as ferritin in macrophages and liver. The key regulator is hepcidin, which is produced by liver. Hepcidin controls the ferroprotein, which is an iron exporter. If hepcidin is increased, ferroprotein what? Role of hepcidin. It is a master regulator produced by liver. stimulated by interleukin 6. Action: inhibits ferroprotein, which leads to decreased iron release from macrophages intestinal cells, which results to decreased serum iron and increased stored iron. Cytokine mediated effects such as interleukin 6, which leads to increase of epicidin, and TNF and interleukin 1 suppresses the marrow, and interferon gamma inhibits the erythroid progenitors. Net effect: functional iron deficiency, blunted erythropoietin response. Pathogenesis: anemia of chronic disease is cytokine mediated. Step 1: chronic inflammation, increased interleukin 6 and other cytokines. Step 2: interleukin 6 stimulates liver and increased hepcidin production. Step 3: hepcidin blocks ferroprotein, which leads to decreased iron release for macrophages and decreased intestinal iron absorption. So it leads to iron present in the body but unavailable for erythropoiesis. Bone marrow findings: normocellular or mildly hypercellular marrow, increased iron stores, as we can see in macrophages, reduced erythroid activity, and in peripheral blood smear, normocytic normochromic anemia early, but later it turns into microcytic hypochromic anemia in later cases. Anemia in chronic kidney disease. Kidney produce erythropoietin. In chronic kidney decrease, erythropoietin production is decreased and there will be chronic inflammation and iron utilization is impaired. So this makes the chronic kidney disease anemia partly anemia of chronic disease plus erythropoietin deficiency. Laboratory profile: hemoglobin is reduced, serum iron is reduced, TIBC is reduced, and ferritin is increased, which is an acute phase reactant. Transferrin saturation and reticulocyte count both are decreased, and ESR and CRP and ESR is increased. Comparison with iron deficiency anemia. TIBC is increased in iron deficiency anemia and decreased in anemia of chronic disease. Transferrin saturation decreased in both the cases. Reticulocyte count increased in both the cases. And ESR, erythrocyte sedimentation rate, which is increased in ACD. Iron deficiency anemia is caused due to lack of iron, where anemia of the chronic disease results from the iron sequestration. Clinical features: symptoms of anemia: fatigue, weakness, and pallor. Underlying disease symptoms such as fever, weight loss, and joint pain. Complication: reduced quality of life, cardiac strain, poor prognosis in cancer patient. Anemia of chronic lead poisoning, which is also known as plumbism, a microcytic hypochromic anemia resulting from inhibition of heme synthesis enzymes, especially ALA dehydratase and ferrochelatase, along with shortened red cell survival caused by chronic lead toxicity. Sources and exposure: common sources such as battery industries and lead paints in old houses and contaminated water in lead pipes, and traditional medicines also contains lead, and high risk groups such as children and industrial workers where they work in such battery industries and lead paint industries. When it comes to pathogenesis, there will be blockage of heme synthesis. So there will be inhibition of the key enzymes. The inhibited enzymes are ALA dehydratase and ferrochelatase, so which results in accumulation of the AL and protoporphyrin and decreased heme synthesis. Mechanism of anemia. Impaired heme production, which leads to decreased hemoglobin formation, and in RBC membrane damage because of lead, which leads to oxidative stress, and reduced RBC lifespan, which leads to hemolysis. Impaired ion utilization, ion accumulates but not used. Peripheral blood smear. Findings are microcytic hypochromic anemia and basophilic stippling, where there will be aggregated ribosomal RNA due to inhibition of RNA degradation, which is seen as blue granules in RBCs, mild anisopoikilocytosis, and bone marrow findings such as erythroid hyperplasia, ring sideroblast may present, and iron-laden mitochondria. Laboratory profile. Hemoglobin is decreased, serum iron normal or increased, TIBC is normal, ferritin will be normal or increased, blood lead level is increased, free erythropoid protoporphyrin is increased, ALA levels are also increased. Clinical features. In children, developmental delay, irritability, and encephalopathy. In adults, fatigue, pallor, abdominal pain, peripheral neuropathy. Complications are neurological damage, chronic kidney disease, and hypertension. So that's all about the microcytic hypochromic anemia. And
Thanks a lot. And thanks to thanks a lot. Thank you.